Hello, my name is Dr. Elizabeth Drum. I'm a pediatric anesthesiologist at the Children's Hospital of Philadelphia in the United States. I'm coming to you today from the World Congress of Surgery meeting in Krakow, Poland. I had the pleasure this morning of moderating a session entitled Pediatric Surgery and Anesthesia in Low and Middle Income Countries, and I'm delighted to bring you the highlights from that session this morning. 5 billion of the world's 7 billion people lack access to safe, affordable, and timely surgical care. The majority of people without this access live in low and middle income countries, and approximately 50% of these are children under the age of 15. So you can see this is a serious problem. Our first speaker this morning was Dr. Zippy Gathura from Kenya at the Nairobi Hospital, and she talked about optimal resources for children's surgical care. An organization goes by the name of JICS. This is a consortium of providers, institutions, and organizations from around the world with representatives from low, middle, and high income countries in a variety of fields, all affecting children's surgical care. Their mission is to define and promote optimal resources for children's surgery in resource-poor regions of the world. They're engaging leaders in multiple disciplines to organize this surgical care. They're prioritizing the voices of on-ground providers. They're a nonprofit organization with a board of directors of 20 members with representatives from both low and high income countries. They have working groups representing each of the specialties involved in children's surgical care, and they have committees that focus on things such as financing, advocacy, policy, research and training, and setting of standards to be used around the world. Our second speaker was Dr. Milyar Derbu, who's a professor of pediatric surgery at Addis Ababa University in Ethiopia, who discussed priorities for training to meet surgical pediatric workforce requirements. The world's population at over 7 billion now is projected to be close to 10 billion by 2050. Sustainable development goals, including reducing maternal mortality, ending preventable deaths of newborn and children under age 5, and reducing neonatal mortality, are all expected to contribute to this growing population. In sub-Saharan Africa, for example, there are many unmet needs for surgery, including close to a third of the needs around the world. And there are 41 million patients a year without surgical care, and 94% of sub-Saharan Africa does not have access to this safe, affordable surgery. Worldwide, there's large numbers of children born with congenital abnormalities, and close to 10% of those occur in low and middle income countries, with death rates of 400,000 per year. Approximately 300,000 newborns die in the world within 4 weeks of birth every year due to congenital abnormalities. Dr. Derbu discussed a study he did at Black Lion Hospital in Ethiopia, where 60% of the pediatric surgical cases were actually performed as emergencies, which gives you an idea of the extent of the immediate surgical need. And congenital anomalies comprise 47% of all pediatric surgical cases. Of the countries in the COSEXA region, which is the College of Surgeons of East, Central, and Southern Africa, all but Kenya have fewer than one surgeon per 100,000 population. Kenya has 1.1, and that is well below the recommended guidelines of 20 surgical obstetric and anesthesia providers for 100,000 population. Pediatric surgical volume providers is even more concerning. In the COSEXA region, there is on average one surgeon for 6.7 million people. And so if you say half the population is in the pediatric age range, then that means on average there's one pediatric surgeon for 3.5 million pediatric patients. In addition, there are a few countries such as South Sudan, Burundi, and Namibia who have no pediatric surgeons at all. In Ethiopia, they started with one pediatric surgeon and now have, through a series of training, consistently have gotten 13 pediatric surgeons. Our next speaker was Dr. Mark Newton, who's a professor of clinical anesthesiology at Vanderbilt University, but spends most of his time working in Kijabe, Kenya, who discussed priorities for training to meet the pediatric anesthesia workforce needs. The population is growing, and although there have been some increases in numbers of providers, and we have been able to increase the numbers of surgical operations that are being done, because the population is growing faster, the ratio of providers and surgeries per population is actually decreasing. Dr. Newton has been involved in training programs for physician and non-physician anesthesia providers for over 20 years in sub-Saharan Africa, and they have had some strategic successes which he highlighted. One of which was to identify regions in the country that had few or no providers and target trainees from these regions to get trained, and then they would return to their home region to provide care. They started this by doing training programs in key countries and also assistant training in countries that had programs already existing. The other strategic items of their development included things like choosing trainees who would then become future educators, develop and use strategic bidirectional partnerships, train surgical and anesthesia providers simultaneously, use new technologies like video conferencing and simulation, design and run postgraduate continuing education and short courses, and learn lessons from the local community, including wisdom from Ethiopian and Kenyan marathoners that this is a marathon and not a sprint. Our next speaker was Dr. Tamina Bhanu, who is a pediatric surgeon in Bangladesh, and her title of her talk was The Role of Surgical Care in Addressing Congenital Anomalies. She highlighted that 8 million children, which is 6% of the total births worldwide, have birth defects, and more than 3 million children die annually under the age of 5, and more than 90% of these are in low and middle income countries. She and her colleagues did a study in Bangladesh in which birth defects comprised 44% of all pediatric surgical admissions, and 94% of these were from poor socioeconomic backgrounds. She highlighted ideas for the way forward, including things such as advocacy and awareness, using screening for fetal anomalies, but also neonatal incidence of anomalies, including screening in things like immunization and vaccination visits. She discussed trying to provide surgical manpower with surgery, anesthesia, and nursing collaboratively, developing surgical protocols, developing ICU capacity, working on financial protection so that patients didn't have financial hardships in trying to provide surgical care for their children, developing research, and then NSOAPs in each country. She also emphasized that in birth defect-related policy and strategy decisions, that surgeons and surgery should definitely be included, otherwise it would not be effective and the policies would be incomplete. Our next speaker was Zippy Gathura from Kenya, who spoke about anesthesia considerations for neonates and children. She had several key messages, including what the anesthesiologist wants the surgeon to know. Number one, no anesthetic is small, even if the patient is small or the procedure is small. The surgeon needs to know and care what the anesthesia provider is doing and planning. And teamwork among the entire perioperative team is key to provide improved outcomes. She talked about challenges for pediatric patients in areas such as vascular access to the patient, airway, monitors, fluid management, blood loss, temperature regulation, pain control, and treatment of congenital anomalies. She also discussed system barriers, which included things like infrastructure, human resource and supply issues. And she also discussed that improving success includes things like system strengthening for infrastructure, workforce, supplies, and processing, for governance in areas such as research and development, policy direction, political goodwill and training, and also partnerships and advocacy. Our final speaker was Dr. Steve Bickler, who's Associate Clinical Professor of Surgery at University of San Diego School of Medicine. And his title was The Rural to Urban Transition and Its Impact on NCDs. The burden of non-communicable diseases is growing around the world, and there's some fundamental biological questions about these diseases, including the role of undernutrition in rural versus urban disease patterns, and the role of poverty related to development of surgical diseases. He's working with others to look at neurobiologic phenotypes for these different diseases, and also looking at environmentally specific signaling that may be causing some of these disease processes. One of the questions is, are there differences in mitochondrial functioning between urban and rural populations? The current global epidemic in NCDs is one of the greatest public health challenges of our generation, and the rural to urban paradigm offers an opportunity to study how the environment impacts global health. And global surgery researchers are uniquely positioned to investigate this epidemic. I'm sorry you couldn't join us in person for our session, but I hope that gives you a highlight of the quality and quantity of our conversations today. Thank you.